So this is the second half of our introduction lesson on diagnosis and interventions. Specifically for this course, we're focusing on what to do in the first 48 hours after an injury or emergency situation. And although the focus of this course is that first 48 hours, we also need to set the groundwork for making these decisions more long term. The focus of how to make these decisions remains the same regardless of whether it is in the first immediate injury treatment window or whether or not it is a more long-term rehabilitation scenario. And so we need to first and foremost come up with the solution on how we go about making these decisions. And that's what we're going to focus on here. So we ended last time with Trevor Bauer and his injured finger. And we talked about what was exactly wrong, on how this is much bigger than just an injured finger situation. Trevor Bauer is a pitcher for the Cleveland Indians, or at least he was back at that time. Right? And he's in the middle of a postseason start where he's trying to lead his team to a 2-1 victory, game lead within the series. And so obviously in this situation now, the injured finger is a problem, but also is his inability to pitch. If you just look on his face, you can see the frustration within his face. And you look at the teammates, they're now all having to pick up the slack. And so despite the fact that he has an injured finger, when we go about trying to treat Trevor, we need to look at much more than just that finger. And that creates what we see as the large web associated with our patients, right? Our patients are much more than just the sum of all of their parts. It's all of these different interactions, specifically with themselves and with us. So you can see all of these different things that can be associated, their goals associated with different things, different aspects with the environment, right? The tasks they have to do, right? The different types of evaluations and all of these interactions that go in the middle. And so that's what disablement models are focused on. A disablement model now is a conceptual model, and the purpose of this model is to provide a framework for clinical practice. So that's what we're talking about, right? We're trying to create a framework, a way of understanding the intricacies of all of these different interactions with our patient. They're used throughout all of healthcare, and that's the primary reason why, despite the fact that a disablement model may not always make the most sense with our patient population, because we have the added benefit in sports medicine of often having a much higher level of knowledge of our patients' goals and ambitions compared to other healthcare providers. But because this is a healthcare profession standard, we need to become fluent in this as well. In addition, this model facilitates integrating research evidence and our patients' values. And we'll see why this becomes important when we get into this idea of evidence-based practice at the end. We need to not only be able to identify what we need to do, right, and what we need to treat, which is more the disablement models, but then incorporate the research right into that. And then lastly, these disablement models help with documentation, and specifically in these long-term documentations of research and the effectiveness of these different interventions that are being used in athletic training and throughout medicine. So 3 main points: conceptual model, right, combining with healthcare and the integration of research, and then lastly with these documentation. So there are different disablement models. The first one that really came into play was Nagy disablement model back in 1965. And so when we look at this, we can see it's basically created of 4 different dimensions with 3 different levels associated with each dimension, right? So we have the active pathology or the active injury, right? And this is what we normally think of. This is the normal diagnosis. In the case of Trevor Bauer, this is the laceration to his finger. It occurs at a cellular level, right? And so you can see here, this is that posterior superior labral injury as the example that it goes. So here's the model here, active pathology at the cellular level, right? We have an impairment then that combines the different aspects of different systems, right? So we have body systems now. In this case, it'd be the musculoskeletal system and the hand, specifically the inability to grab the baseball, right? And in this case, the inability to stop bleeding, right? Without the ability to grab the baseball without bleeding, it impairs the ability for that system to function, right? So in this example, also we see posterior superior labral injury, decreased strength. That then gets to functional limitations, right? From that aspect, now it's whole person. So both examples here come into play. This functional limitation is now the inability of the entire person to perform some sort of action, right? That action in this case is the ability to throw a baseball, right? And that is the limitation. But then it goes to the disability, and that's the person's relation to society. And in this case, same thing, the inability to fill a role as the starting pitcher, right? This is the interaction between our patient and their role in society. Specifically, oftentimes, this is associated with ability to perform these tasks related to their job. That's the most common aspects, or other daily life activities in which they're interacting with other people. And so although it's not particularly important to understand the specifics of the entire model, I do want you to understand what each of these categories are relating to. But knowing the specific order and all that isn't as important as knowing that we need to go beyond this simple active pathology, what we normally think of as our diagnosis, and look for how that is going to impair the overall ability of the individual to perform larger functional activities, and then complete body activities, and how that relates to their role in society. So that's obviously an older one. The most common now is the ICF, or the International Classification of Functioning, Disability, and Health. In 2015, the NATA Board of Directors adopted this as the official disablement model for athletic training. And so this model goes into a larger venue, as well as the ability to integrate much more within the model itself. So you can see some of the additional aspects there, but I think the best way to really look at the ICF model is to get started. And so when we think of this, it's more than a model. It is this comprehensive approach. It is a way to understand that complex web of interactions within the patient, healthcare, the environment, and society. And so we also then, because of the comprehensive nature, want to make it to be able to use it throughout all of healthcare. So we will see some of these documentation things come into play as well, because if we're going to go through and create a model that shows how all of this is integrated, we also then need to see how things are occurring at a larger level. This is taking healthcare beyond just the individual and the individual's role of society, and then society going back to the individual. So here is the ICF model. We have the health condition at the top. Then we can see how that interacts with body functions and structures, activities, participation. And then we also see that environmental factors and personal factors are interacting. And the most important thing to see with this at this point is how arrows are going both ways. This is all interacting. So we have the health condition at top, right? That is going to be what we normally focus on and what normally starts us into the healthcare environment. And so we then need to go beyond that to start looking at the functioning and disability associated with that, right? So how is our body's functions and structures going to be affected anatomically and physiologically? How are activities that are going to be done by the individual affected by the condition? And then participation is that life situations, the societal factors, what we saw as disabled in the Nagy model. Then we also have, beyond that, right, these contextual factors, the idea that the personal factors associated with that individual, their age, their gender, race, lifestyle, habits, are all going to also be affecting their body function and structures, their activities, and their participation, right? Somebody may or may not have the ability to heal as well based on their age. If they're an older individual, they may not be able to heal as well as a younger individual. That's affecting their body functions and as well as their activities and participation. At that same note, there are environmental aspects, whether that is physical, societal, or attitudinal. All of these things will affect their response to that initial injury that we're trying to treat. If somebody doesn't have access to healthcare, for example, or oftentimes it's possible that our patients may not have very good insurance, and so we serve as their primary and oftentimes only access to the healthcare system as athletic trainers. And so without those abilities, that obviously changes how we're going to deal with these injuries. So when we come back to the model then and start to overlay that, we have the health conditions, we have these anatomical and physiological aspects that cause the injury. And so we can think, how does the health condition affect the anatomy and physiology? How does the health condition affect the tasks or actions to be taken by the individual? How does the health condition affect the involvement in life situations? But at that same note, how does the environment affect the anatomy and physiology? How does the environment affect tasks or actions? How does the environment affect involvement in life situations as well as personal factors? And so you can see now within this model, we are now creating a situation where we are looking at all of these different actions so we can account for them in making our treatment decisions. We then have a documentation form that allows us to take what we have found and start to categorize that according to different goals and different interpretations with that. And so from that standpoint, we create situations of function. And this is the main aspect of the documentation, is we are going to take this and look at changes in function from severe and complete limitations to no problem or mild limitations within these different functions. And then once we have the ideas of functions, we can start to see how we can make changes to affect these levels of function. So when we look at this as an entire model, and specifically in the areas of athletic training, we're looking at the influences of this conditions on other areas of life and vice versa. So specifically going back to our example of Trevor Bauer at the beginning, right? The easiest solution to his problem would have been for him just to not pitch, right? That would have allowed for the stitches to do their job, allow for the finger to heal, and there would be no problem. If all we were dealing with was a lacerated finger, that's a relatively easy problem to deal with. However, we had to deal with his ability to throw a baseball. And so then that creates another series of interventions. And so at that point, we can start thinking, okay, how can we control bleeding? What sort of interventions will allow him to hold a baseball and throw a baseball. And so, whether it's gluing or, bandaging, all the normal things that you would do so that the individual could throw a baseball. But the last thing also comes into play with his roles in society, and those aspects as far as his daily living focus then on his being a baseball player. And in baseball, as a pitcher, you're not allowed to have any foreign substances on your hand. So you can't glue it, you can't put bandages on it or any of that sort of stuff. So how can we go about focusing on that? Another example here you can see talking about another injury and the possibility of health insurance and how that might affect their academic responsibilities. And so we're looking much more than just sport participation in this holistic patient care. So when we're looking at disablement models and the functions of this, we're trying to create a system that focuses on this problem-based treatment. So we talked about the problem-based medical record and that focus, but now we're looking at problem-based treatment. So when we go and we consider the use of the ICF model, we get to a point where we have our assessment, we know what is wrong with them, and we're trying to get down to therapeutic interventions. And so from there, we create the problem list, what sort of problems are occurring. These can be from the environment, they can be from the injury themselves, they can be from any sort of different aspects, but they all come into these problems. We address the causes, create goals, and that's how we're going to create our interventions. So you've seen the normal aspect where we start with our evaluation and we have history at the top, work our way down till we create an assessment. But in problem-based medicine and using the disablement models, we're only about halfway there. We then have to create that problem list, the things that are wrong that we need to address. What causes those problems? What can be our goal, which is usually just addressing the causes, and then what therapeutic interventions reach those goals. And so you can see how we get down to this situation where we have not only in this trying to figure out what the health condition is, but trying to figure out the physiology and anatomy implications, the activity implications, the participation implications, the environmental factors and personal factors, and all of those different interactions to come to a situation where we have problems lists and causes and goals and therapeutic interventions. But then we need to be able to actually apply this. And to apply this is the application of evidence-based practice. And so when we get to evidence-based practice, you can use evidence anywhere within these different aspects to understand what to do, because this explains how to think about it, but evidence-based practice is going to focus on how to do it. So let's take a look then at where you can use evidence and how we can put all of this stuff together. So when we're looking at clinical decision making, we have to get down into how we decide specifically what to use. We have a framework now in place that has led us from our initial evaluation, right, and the history of figuring out what is wrong, to the assessment, through problems, down to our treatment interventions. But how do we know what is effective in each of those steps at giving us the information that we need so we can get to the right decision? If we don't have the right diagnosis and the right problem list, then we won't have the right interventions. At that same note, how do we know what interventions are effective at treating each problem, right? We can get to a situation, and sometimes it feels like we're just spinning a wheel for different treatments, or oftentimes even more so, we have this idea that somebody with an ankle sprain, we do X, Y, and Z. And what we figure out with that is X, Y, and Z really the best treatment? And evidence-based practice tries to focus on answering that question. So I'm going to introduce evidence-based practice today, but we have an entire course on evidence-based practice towards the end of your time in your level 3 January term. And we do that, I like to introduce it here. So at this point, I want you to focus more on the steps and the definitions. And then the real how you're going to do it is once we've gone through most of the curriculum, we can focus on how do you go back and figure out why, where, and how. So most importantly, we have to define what evidence-based practice is in evidence-based medicine. And there have been a lot of different definitions proposed. This one by Sackett seems to have got the most traction with that. And so evidence-based medicine is the conscientious, explicit, and judicious use of current-based evidence in making decisions about the care of individual patients. The practice of evidence-based medicine means integrating individual clinical expertise with the best available external clinical evidence from systematic research. So when we look at this, right, there's a few things to focus on. It's conscientious. This is something that you consciously choose to do, but it is an integration. And so those are the two things that you need to focus on out of this definition. First, how do I consciously decide to do it? And second, how do I integrate it? And then the why is relatively simple. To decrease medical errors. There are way too many medical errors that are done due to poor knowledge within medicine, where we do things that are outdated or are just not effective. And that goes back to the idea of because we've always done it that way. In a lot of these courses, we talk about specific techniques, and these are the best techniques that we have at this time. Obviously, the techniques are going to change, and so practice has to change. And the idea with evidence-based medicine is that what we're doing constantly needs to be updated and integrated with research and the best available evidence. And so how to go about do it and what evidence-based practice really is can get very complicated very fast. You can see from the Board of Certification, different aspects on you have to get evidence-based practice credits, some old things there. But the real aspect comes, what does all of this mean? And so here is a visual interpretation of what evidence-based practice is in evidence-based medicine. And it all focuses on decision-making, making the best decisions. So within that model that we saw before, we have different points that we are actually making decisions. We have to make decisions based on what clinical tests we're going to use during evaluations. We have to make decisions on what sort of physiology and anatomical expectations do we have from the different conditions. What sort of interventions are most appropriate for these specific goals. These are the decisions that we are making. So how we go about making them is first and foremost, we need to understand ourselves and the resources we have as a practitioner, our idea with clinical expertise. We include the best available research evidence and the population characteristics, needs, and values and preferences of our patient. And so where all of these overlap, this sort of area right here in the Venn diagram is the quote-unquote sweet spot for that specific situation. Notice the interactions and integrations of these three circles. But also keep in mind, we have the environmental and organizational context as well. The idea that within our own organization and the environment that we're working in, there are going to be different abilities and different things that we can focus on or we have to deal with. We may like to do a specific intervention, but if we don't have access to that intervention, then we're unable to do it. And so let's look at each of these in a little bit more specificity so we can get closer to how to do this. So first, let's focus on clinical evidence because that seems to be the one that makes the most sense with this. We talk a lot about evidence in evidence-based medicine. for obvious reasons. And this is using research and research articles to help us answer specific questions. So we see the hierarchy of evidence and the different components. And so we now get what we can consider external advice, whether it's from other experts or from higher levels of research, but we are going to go out and try to find additional sources to help us decide what we are going to focus on. We also have our clinical expertise, the fact that we as clinicians have been building a practice and we've been getting our own experiences, and we have a certain amount of ability to understand what works and what doesn't work based off of what we've done previously. Right? And so in this case, in clinical expertise, it is the clinician's values, preferences, and experiences that are being included. Right? If the clinician doesn't believe in a treatment or doesn't have skill in performing the treatment, it's not going to be effective, even if it is the best treatment as recommended by the research. And so the importance comes is that these are on the same level, right? You should not have your clinical expertise being the only thing that makes decisions from that standpoint. That I've always treated it that way, because that can get you in trouble. But at the same note, you have to be able to interpret the research as well as be able to implement the research for it to be effective as well. But the third portion there is the patient values. And this is where the ICF model really helps us in that, is to focus on the patient as much bigger than just the condition, right? What are the patient's goals? What are their preconceived ideas or beliefs with that? And so how can we take this and incorporate not only the evidence that we find as far as what is supposed to be most effective, as well as what we have found to be effective and what we're good at, with what the patient values and what the focus is for the patient and at that aspect. And so it all comes down to this idea of trust or distrust with medical professionals, right? You have to create a situation where the patient is involved with their own health care. And that's important beyond just athletic training. That is a focus of all of medicine right now, making sure that we are focusing on our patient as more than just an injured ankle or an injured shoulder, but everything going on associated with that patient. And so we will try to do the same when we talk about treatment interventions within that most vulnerable first 48 hours. So now that we have a good idea of what evidence-based practice is, I want to focus on the 5 steps of evidence-based practice, and this is how you go about doing it. So at this point, I want you to know the 5 steps, but we will go into much more detail later on and how to do this. Just trust at this point that when we're talking about different treatment interventions, we're following the best evidence-based practice, and we will give you access to a lot of that evidence and have those discussions during this, but we won't make you do these 5 steps each time. The first step is creating a searchable question. And I think of this as the idea of the whole needle in a haystack, right? But in reality, it's more a needle in a stack of needles. If you don't know specifically what you are looking for, you will never be able to know how to find it. And there's just way too much research and way too much information as far as this information age to not specifically have a good idea of what we are looking for. And so with this, we need to go and figure out what our patient or clinical concern is and focus on one specific concern that is searchable. So we have to be able to create a situation where we can figure out what specifically we are looking for. And that is the PICO question. And PICO is an acronym for P is patient population or problem, I is the intervention or the treatment, C is the comparison intervention, and O is the outcome. So if we're looking specifically at trying to identify a treatment for a specific problem, right? So let's say that we are trying to treat pain. we need to understand that within pain, we need to specifically look at our patient population. It makes sense that treatment interventions for low back pain and a fractured ankle are going to be completely different because the pain and the patient population, the patient being one with low back pain compared to somebody with a fractured ankle, are completely different. So we need to look for, in this case, if we're looking at low back pain, we need to specifically make sure we're looking for articles focusing on pain similar or including low back pain. Then we look at the interventions that are used. What sort of interventions do we have available to us, right? Is something effective? Is the only way we can really figure it out? Because if we just go and say, what is the best? How do you go about searching for the best, right? You get somebody's opinion that's usually trying to sell you something. So we need to then focus on this idea of comparison. And so we pick one. Let's maybe look at, TENS and E-stim versus moist heat. So we have to have two things to compare them to in order to decide which one is best. But even then, once we have two things to compare, we need to have an aspect of what to compare them on, whether or not, and that's the outcome. The outcome can be, pain reduction. It could be range of motion improvement. It could be return to function, right? Our goal may be to decrease pain, which is a physiological goal, but at some point we also have larger goals: increase range of motion, increase return to function, all those sorts of things. These are different outcomes that we have. So this might be the actual definition of the goal. So this is the patient we're dealing with, the two interventions, and the goal that we're trying to accomplish. Step 2 is to conduct a database search and go ahead and start to get the articles. This is the stuff that you've been doing the most. Different used databases are listed there. And the ability to search those databases is always helpful in the different techniques, but probably what you're most used to doing. Step 3 then is where evidence-based practice really gets into play, where we have to start integrating that. And the integration comes from the critical appraisal of the evidence. We have to be able to identify the applicability and quality of the research, and specifically how that is going to affect us as we make our clinical choices. So step 3 is critically appraising the value of the research, because we're not just going to do what the research says, because that's not the integration that is evidence-based practice. Once we get to that, we have to synthesize all of that as well. So now once we know we have quality components, now we're specifically going to synthesize that by considering the patient values, our own clinical expertise, as well as our comfort in trying these new protocols. So we've gotten all the articles, we've assessed whether or not they're applicable with us and whether or not they are able to be integrated, and then comes the actual aspect of integration. And then the last step with that integration is to assess whether or not it worked, right? So step 4 is synthesizing and doing it. And then step 5 is assessing the outcomes. Was our treatment effective? Was that effective in both the injury status and the athlete's impression? So this idea of both, things that are important to us and things that are important to the athlete. And so we call these clinician-derived measures and patient-derived measures. And so we will talk a lot about assessing outcomes, and specifically patient-rated outcome measures, or PROMs. And PROMs are the newest tool to assess whether or not we are in fact making progress with our overall goals, and making progress according to what is important to the athlete or the patient. The patient fills these out and they show progress over time. And this is what is required to show effectiveness of treatment. When we do something, we want to say that it is going to be effective at treating these specific goals. And patient-rated outcome measures are the way that we do that. So that is the end then of this introduction unit. And so at this time, hopefully you have a good understanding of where we are going as a class, but also a much bigger picture of how you go about making clinical decisions and specifically picking the interventions. In class, like I said, we will talk a lot about the interventions and what to do in different situations because we will have already done this evidence-based practice stuff for you. But I want you to understand what is going on in the background so eventually you too will be able to do it. As always, if you have any questions, please let me know. Otherwise, have a great day.